Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled Advances in Mitral Valve Surgery. If I have yet to meet you, I'm the patient who started HeartValveSurgery.com all the way back in 2006. Our mission here is real simple. We want to educate and empower patients just like you. And this webinar, which has had over 350 registrations from patients in countries all over the world, was designed to support that mission. Now, during the webinar, you're going to be in what's known as listen-only mode, but I'd encourage you to ask your questions using the control panel, which I believe is in the bottom part of your screen, and I'll explain to you why that is. When we look at the agenda for today, I'm going to introduce the wonderful featured speakers, and then we're going to talk about mitral valve disease, mitral valve treatment. We're going to have Q&A along the way. And then we're going to have a very quick 5-question survey. So let's dive right into it. And it is my honor to go ahead and introduce you all to Dr. Joanna Chikwe, who is not just the chair, she's the founding chair of the Department of Cardiac Surgery in the Smith Heart Institute at Cedars-Sinai. Her specialties are heart valve therapy, minimally invasive techniques, and robot-assisted mitral valve therapy. She's published not one, not two, not 10, but a lot of articles and research on this very important topic. And I've been fortunate to know Dr. Chikwe. We met in an operating room in New York City well over 10 years ago. We were watching an aortic root replacement. She was participating in it, and she's just a great person. I'm so thrilled to have her on the line. Thanks for being with us, Dr. Chikwe.
Thanks so much, Adam.
Yeah, and so now let's move over to another great person to have on the line, who is Wendy Spector. And I've just gotten to know Wendy, but what do we need to know about Wendy? Well, she is a mitral valve patient. She was treated actually by Dr. Chikwe back in June of this year. So it was being done during COVID. She had the surgery performed at Cedars-Sinai. And she's a loving wife and mother of 2. And Wendy, I can't thank you enough for bringing the patient perspective to this webinar today. So thanks for being with us.
Thank you.
Thank
and
you.
I have to say to Dr. Chikwe, I'm so happy to see you this way.
Yes.
Instead of the OR.
Thank you so much.
Yeah, and so I could go on and on about the achievements of Dr. Chikwe and the entire team there at Cedars-Sinai, whether it's Dr. Trento, Dr. Ramsey, Dr. Ismailian, Dr. Carr, although he's moved on, Dr. Mukhar, excuse me. But what I like showing is the smiling faces of the patients in the HeartValveSurgery.com community that have had some incredible results at Cedars. So whether it's Josh or little Leilani or Jerry Andis or Florence or Patricia, Steve, Rich, this is what commitment to heart valve therapy looks like. It's the smiling faces of patients who have incredible, incredible outcomes. And to learn all about the approach that Dr. Chikwe and her team takes, I'm going to go ahead and turn over the webinar to Dr. Joanna Chikwe.
Hey, Adam, thanks so much. And I thought it would be great if we could just really answer some of the questions that your community have sent in. And Wendy, I think it's just wonderful that you agreed to do this, and thank you for doing it at such short notice. Maybe we could start with this one. I often tell people that ask, what might I feel, that you might feel nothing at all, you might feel completely fine. From your perspective, what did you feel around the time that you were diagnosed with mitral valve regurgitation?
For me, I had a quirky other issue going on with my sternum. So I don't believe I was feeling anything. However, while trying to diagnose what was going on in my sternum, they found the mitral valve regurgitation. So at the time I was diagnosed, which was probably 4 years ago, it was considered moderate. At the beginning of, I guess, January 2020, I started to have like mild, just little flutters and a little bit of, I guess flutters and erratic. So that sent me to get an echocardiogram, I think 6 months later. And they looked at it, that it was severe at that point.
So you're one of, I would say maybe about a third of people that I see in the office with severe mitral regurgitation either feel fine or just have slight palpitations.
Correct.
And then maybe the other 2/3 are feeling more limitations. So that might be feeling winded when you're just walking and talking or walking up a slight hill. Some people feel chest pressure or discomfort, not usually pain. And then fatigue is a really common complaint. It's amazing the number of people that say, I just feel completely de-energized. And I would never say that surgery will fix that because there's so many causes of fatigue. But I always do say, I'm surprised at how many people say their fatigue gets better once you fix their mitral regurgitation. And there's one question from Joel Kaplan that says, is near syncope with shortness of breath symptoms? So syncope means near fainting. It's literally you're blacking out. And syncope can be caused by many things that go on in your heart. One of them is for sure mitral regurgitation, although it's not a common sign of mitral regurgitation. People sometimes say they feel breathless or dizzy when they bend over. But if you've got an arrhythmia, that's an irregular heartbeat, that could make you feel like you were about to black out. And then very tight valves can cause syncope. So should we go on to the next slide, Adam, and take a look at, that's the summary, I feel fine, a lot of people, breathlessness, chest discomfort, palpitations and fatigue. And the next slide is a question, I think, really about what are the causes of mitral valve disease. So here, and this is a real mitral valve, it's a very normal looking one. The thing that's causing this valve to leak is actually because the framework, the skeleton of the heart has stretched. So the valve itself is completely normal, but the leaflets don't meet. And the way we fix it is to make that skeleton whole and tight again with this ring. This valve is holding saline under pressure, which tells us in the operating room that it doesn't leak. So you can see there's a jet of fluid that comes out, it holds it under pressure. And now this white material beneath that purple line tells us that the amount of valve that is coming together there in the echo shows that that's a beautiful valve, there's no more leak. So that type of valve problem is now treated in many centers by a MitraClip. It's very different to what Wendy had. If you're a little bit squeamish, I'm going to tell you to look away from the screen from the next two videos, but these show mitral valve prolapse. So Adam, if you wouldn't mind hitting the next slide. So this is prolapse. This is what many people that are searching for a repair had. And it's just caused by sort of floppiness. So you see this little bit that's coming up here. In the other video, all of these cords were intact. That's a broken cord. That cord no longer attaches that bit of the leaflet to the skeleton and the inside of the heart. That's why that leaflet flips up. And that's the cause of a leak. And this is a beautiful thing to repair. And we're repairing it here robotically. This is not Wendy's video, but it's very, very similar to what we did. So I hope, I'm curious, Wendy, what do you think as you're seeing it?
I'm so glad I'm on the other side of it.
I can only imagine. I can only imagine. So that
I did a lot of research, but I did not do that.
So this is, we just cut out a little triangle of that floppy bit, and we're now just going to sew the edges back together. The edges are the bit that's normal. We've cut out the bit that had a broken cord, and it's like repairing a parachute. If you imagine a parachute is kept in place with lots of cords and the cords break, you might have a little bit of the parachute flipping up as you're sort of falling down through the sky. And really what we've done is cut out the flippy bit and bring the edges of the bits that are well supported back together. And that's how you do essentially how you do a mitral valve repair. The last thing you'll see in this video is a little band that we place around the valve, a little bit like the last one. And that's really, really important because we really understand that that's what's necessary to avoid this valve leaking in the future. So you can just about see that band going into place. This is testing the valve by injecting some saline just to see if it's watertight. And you'll see that it is. It holds the fluid really, really well. And the next thing that you see is the echo after surgery. And that shows, again, no leak. And that's really important for us. We want everybody to come out of the operating room without a leak. And then again, if you're squeamish, don't look at the next video, but what I'm going to show you is a Barlow's valve. And that's a really complicated one to repair. And if you remember what you've just seen, you saw the nice floppy normal valve to start with. You've just seen a really common P2 prolapse, we call it. This one is Barlow's. This is much more complicated, and I think you'll see instantly why. Do you want to press next? And let's see how this one looks.
Dr. Chikwe, as we're getting interactive here, I'm trying to put my thinking cap on for some of the patients who are on the line, and they're hearing these terms like cords and prolapse. And I kind of want to focus real quickly on the cords. The mitral valve, as I understand it, is pretty unique in that it has cords where other valves may not have valves. Is that true? And can you talk about what is the purpose of those valves, of those cords?
Yeah. Absolutely. So it's a little bit like a parachute. The cords are what help the valve work properly. And the other valve in your heart that has cords is the tricuspid valve. That's on the right side of your heart. A very interesting study that's going to be hot off the press at the American Heart Association this week. It was looking at whether the tricuspid valve should be repaired at the time of mitral valve surgery because it often doesn't work very well. And putting in new cords is one way that many surgeons treat the mitral prolapse that we've just seen. And that works very well for many patients. So if you're squeamish, look away. If you're not, here's a Barlow's valve, most complicated thing that we get to repair. And I think you can see here how completely abnormal this valve looks compared to what you've just seen. So if you take one thing away from that, is if you've got a diagnosis of Barlow's valve disease, your surgeon's going to have to do a pretty complex repair, and you really, really want to take that to an expert. It's hard to get these valves to work beautifully because, as you can see, every single bit of this valve is not normal. It's completely different to those valves that you saw before. The cords are all long, they're not the right length, and that's why this valve leaks. Okay, let's get off the sort of surgical videos and back where people can look at the screen. So let's go to the next slide. So here's a question from John who says, I was somewhat shocked to learn that I have moderate to severe mitral regurg. I'm an athlete and I want to continue running pickleball and golf. Can surgery eliminate symptoms and get me back to normal? So I'm curious, and this might be a high risk question because I haven't asked this of Wendy recently. Could you describe how you feel now? And remember, Wendy felt pretty normal at baseline. And sort of what was the trajectory of recovery that you had? How long did it take you to get to feel good?
For me, honestly, I as I was saying to Adam earlier, I found it very undramatic, which is a very positive thing. I think the anticipation prior is so much worse than the recovery. My recovery in the hospital was, I think 4 days, I believe. And while it's not, I would not say it wasn't smooth sailing. Obviously there was pain, but it was very tolerable. Now and actually thereafter, I never felt like I had major surgery. It was something that was very surreal to me. It was uncomfortable, yes, but it is very tolerable. And of course, I had minimally invasive, which is a little bit easier, a little faster recovery. I went into it, as everybody agreed, at a very good time instead of letting anything further progress, I guess. So I want to say the anticipation, which I have heard from so many people, is so much worse than actually going through the surgery. And yes, you can get back to a very normal life. I'm doing cardiac rehab now for a couple of months. That's all I intend to do it. And it's more, first of all, it's the assurance of they monitor you for the first couple of, well, for all of the sessions, but for the first couple of sessions, then you can become more confident, I suppose, that you are strong enough to do what you want to do. And after, for me, it's pushing me to actually stay on a regimented exercise path. But I feel fine. I'm good.
That's just so great to hear. I think surgeons often have an overly optimistic view of how fast the recovery is. And we say things like, back to normal in a few weeks. But genuinely, I think it takes people much longer to get truly normal. And
I agree with that. It's not, I think you do feel normal in a few weeks. You feel like you've been through something, but it really, I mean, I was walking, as you know, a couple of days later, I was doing several miles. So it was not dramatic. It was an easy uphill or downhill, I'm sorry, recovery.
And to speak to John's question, and this is where I turn into a bit of a mitral repair evangelist, the whole point of a mitral valve repair is to get you back to normal. The most important part of normal is a normal length of life. We want you to have a normal life expectancy, as if you didn't have anything wrong with your heart. And mitral valve repair is an amazing operation because it's one of the few things we do that, if you do it right, gets you back to a normal life expectancy. And it should get you back to a normal quality of life. So we've all operated on patients who are older and more limited, and a few of us get to operate on athletes. And it's really, really rewarding to get somebody back to running their marathon. Is just completely the goal of surgery. So I think you should be able to get back to pickleball and golf, no problem. And the only thing is, it'll be putting for a few weeks and save the big swings until, if you had a stenotomy, until that's really well healed. Can't say I will improve your handicap, but you should be able to be back on the golf course, no problem. The next slide, I think, gives you a sort of a sense of that. This is a graph, and it looks at about 500 patients that had robotic mitral valve surgery at Cedars over 5 years after surgery. And what you're seeing is their survival without recurrence of their mitral regurgitation. So that answers a couple of questions that are in the chat there. We've looked at patients, and we looked at people that had Barlow's disease and people that just had more straightforward repairs. And oftentimes surgeons struggle to repair Barlow's disease. So you see slightly worse survival. You see a lower line there in the blue. But in our hands, you can see at about 5 years, more than 95% of people there are basically alive, doing well with minimal mitral valve regurgitation. So that's the kind of outcome that you want to look for when you're looking at the surgeons and the centers to have your surgery. This really great 90%, 95% freedom alive from mitral regurgitation out at 5, 10 years and longer. We're really shooting for the long term here. Adam, any thoughts as you listen to some of this?
No, you know what I was going to ask of you, Dr. Chikwe, is obviously we've heard so far the mitral valve repair, mitral valve repair, mitral valve repair, versus a patient who might be fixated on a mitral valve replacement. As patients, we often think of the new out of the box where consumers, hey, I want a new mitral valve replacement. Can you maybe spend just a little bit of time talking about why a repair is so beneficial for patients? I know you've referenced a couple of things, but it might also help for them to compare that to the realities of a mitral valve replacement.
I think that's a really great question, and it's going to lead into the next few sort of discussion points. The reason a mitral valve repair is so much better for you than a replacement, if you kind of have the floppy mitral valve that Wendy had, so your leak is caused by prolapse, is because it's the only operation that we do that gets you back to a normal life expectancy. Mitral valve replacement is better than doing nothing if you have a severe leak, but it doesn't get you back to normal life expectancy. You're taking a few years off your life. If you have an animal valve, which is one of the options, a tissue valve, you're probably buying yourself another operation down the line. And if you have a mechanical or a metal valve, less likelihood that you'll need another operation, but you will have to take a blood thinner. And both of those, and this is important, both of those kinds of artificial valves have a slightly higher risk of stroke every single year that you have them than a mitral valve that's naturally yours, i.e. your repaired valve. So all in all, there are very strong reasons and important reasons to try and get a mitral repair. And if you can't have one and there was no other option, a replacement is not the end of the world, but it just isn't as good long-term for you as a mitral valve repair.
Thank you so much. And I guess a follow-on might be, we're going to have patients who have mitral regurgitation. They might have mitral and tricuspid regurgitation. We might have patients on the line who have mitral stenosis. Can you talk very quickly about, and I don't know if it's in the slides coming up, about treatments potentially for those patients?
Yeah, sure thing. So we can talk about them coming up. And before we get to that, I'm just curious, Wendy, if when you were thinking about, because you traveled quite a long distance for your surgery, was that a driver in your decision making? Like what's prompted you?
It absolutely, yes, it absolutely was. Initially, I was given the diagnosis. I that night went home and started or actually had the diagnosis, but was told that it was most likely I would need surgery. I went home that night and immediately started researching. I had narrowed it down to 3 or 4 of the top institutes that primarily work with mitral valve repairs and or surgeries, and I was actually scheduled with an East Coast. I'm on the East Coast. Dr. Chikwe's on the West Coast, furthest points, and had scheduled with an East Coast top facility. However, I kept coming across Dr. Chikwe's readings and writings, and I kept going back to certain things that she had said, and I initially had thought a sternotomy was the only way of surgery. And upon reading, and of course, because I had problems with my sternum, I didn't want to aggravate anything there if I didn't have to. So for me, I knew I wanted a repair, if possible, no replacement at all. I knew that I wanted a top surgeon that could do that repair and was comfortable with repairs. I was referred to somebody locally, and good surgeon, but that was not his specialty. So I knew I did not want to do that. And I wanted to do minimally invasive, just not to aggravate again the situation. So I was scheduled with an East Coast facility. I decided to take a shot and call Dr. Chikwe's office because I knew she was familiar with a lot of the facilities. She was so well written on the subject. In my wildest dreams, I never thought I would go to California, but I figured, okay, take a shot and see if she could at least give me a recommendation. Left a message for her if you wouldn't mind just yay or nay with this facility. And her assistant said, well, why don't you talk to her yourself? And so, of course, we were scheduled for a half-hour Zoom, which turned into over an hour. And by the end of it, I said, I'm coming to California. That was it. She was so thorough as she is now in laying out the pros and cons of the different types of surgery, of the point of doing it now rather than later, still being very moderate in her thinking. She wasn't aggressive, soliciting that I had to have this done imminently, but to my benefit. And there you go.
Thank you so much, Wendy. So the chat's kind of exploding, so we'll come to some of those questions soon. I want to address the question that Adam asked. So if we go to the next slide, because some of these things tackle it. So for those of you that, like Linda, need aortic and mitral surgery, or maybe tricuspid valve surgery, the answer is yes, these can all be done minimally invasively, although I always use the word minimally invasive with a slight eyebrow raise. It's all open heart surgery, okay? We are stopping your heart and opening it and repairing and fixing these valves. So the next slide shows you a minimally invasive incision. So the incisions can be very small. And this is a patient, this is about 3 months after his surgery. He sent in this to show us. And the incision is actually, it's about the length of the short end of a credit card. It's under his nipple. And you can barely see, exactly, thank you, great. You can barely see it. And then he's got a couple of port sites. So those little dimples, exactly, perfect. That's for us is minimally invasive surgery, but it was still open heart surgery. The only minimally invasive thing is it's a dinky incision with a slightly, he felt, much better recovery. You can do an aortic valve surgery through a similar size incision, more towards the front of the chest, and you can certainly do tricuspid valve surgery that way. And for those of you that have maybe had previous aortic and mitral valve replacements, we are definitely increasingly doing more of those through the groin. So transcatheter techniques. So that would be TAVR in the case of aortic valves, and then TIMVAR in the case of mitral valves. And that is definitely an option for a larger number of patients. I always tell people that for most people, redo surgery is not a huge incremental risk. We often do it through the same small incision, but it is really great that there are now transcatheter options which don't involve open heart surgery. And the only caveat is we haven't been doing them for long enough collectively as a specialty to have the same 10-year, 15-year follow-up data. We know they're really good for maybe 2, 3, 4 years, but the jury's out on whether these are as great long-term. But certainly you have a much bigger range of options now to treat any kind of valve disease than we did even 3 or 4 years ago. So let's go to the next slide. So this was a question from Tina, who asked, given my mitral valve disease and what I've seen at your website, I'd like to get a repair. What questions should I ask the surgeon to figure out if he is a specialist? So I'm going to ask Wendy, how did you get a sense of which of the surgeons had enough specialist interest for you to be confident in them?
I read and read and read and just kept researching each hospital who specialized in mitral valve repair. I again, locally, they were talking about replacement. I knew from my research that I definitely did not want to do a replacement. I thought that I sent my scans to different facilities, to you as well, and compared. The only thing I could say, you need to be thorough and you need to go with what you're comfortable with. I had spoken with Adam. It's difficult, it's scary at first, but you have to get past the chatter. There's a lot of chatter when you start to do your research, and it can be very intimidating and make you very anxious. And you just need to have a focus as to what's important to you. I personally liked solutions, so I knew the 3 of the big criteria that I wanted fulfilled, and not get caught up with a lot of the what ifs and the what could go wrong. Just find what could go right by the right surgeon and who has the expertise in the field. And so for me, I kept coming back to you. I would read. There were several that to choose from, but for me, I clicked with you. I liked your writings, and that's how I decided on California. I don't think I think in this case the travel isn't the issue. So if you're going an hour away from home or 5 hours away from home, it's finding the best, which for you.
That is really, really helpful. And the other thing that people may find very helpful is Adam's website, which has this great list of questions that you should ask your mitral valve repair surgeon. If you go to the next slide, this is some of the research that helped us formulate these questions. So this graph shows you all of the hospitals in New York State that do heart surgery. And it shows you the percentage of patients with floppy mitral valves that we're saying we should absolutely repair these valves because it gives you a better life expectancy and better quality of life. So you should have like a 99% repair rate. This shows you the percentage of those valves that were actually repaired at each of these hospitals. So the thing that's really striking about this and really surprised me when I did this research was that there's so much variability. Depending on which hospital in New York State you go to, and this is the same across the country, your chances of getting a mitral valve repair could be almost 100%, or it could be as low as 30%. I mean, that's really shocking. And that is driven by, and you'll see the next slide, this variability amongst individual surgeons. So each red dot on this slide represents an individual surgeon in New York State. And on the horizontal axis, you've got the number of times they do mitral surgery on average a year. So yeah, 50, 100, 150. And on the vertical axis, you've got their repair rate. So the percentage of mitral valves that they repair. So you've got these guys at the top with 100% repair rates, and those guys, yep. And that's kind of the surgeon that you want, 100% repair rate or 95% repair rate. And then the guys below 50% are not the mitral valve experts. They're replacing an awful lot of valves that should be repaired. So that's one of the key things you want to ask your surgeon is how many valves like mine have you repaired? What is your percentage repair rate? And what are your outcomes? You know, what are my chances of getting through the surgery, doing well, and having a good repair that lasts with you? That's more important than the size or the location of your incision, ultimately. It's astonishing that there's this much variability, and it's quite difficult to find out numbers like this. If you go to the next slide.
Yeah, and Dr. Chikwe, real quick, if I was to look at these last two slides, and who knows what other goodies you have coming up, but if I'm a patient, I've got mitral regurgitation, I really want to take inventory of these two slides, because this could be the difference of you having a return to normal life expectancy, or you potentially not even having an option for a repair. And I got to tell you, my eyes, Dr. Chikwe, I go, I'm always an optimist, and I'm looking for those people, but reality is down. You know, you got a lot of folks down here. On average, do you know about how many mitral valve repairs a surgeon may do on an annual basis? Is there some kind of research that tells you how little or how much they do?
That's a really great question. And when we've looked at the national data for the whole of the US, the average number of times that a cardiac surgeon, a heart surgeon in the United States sees the mitral valve a year, well, actually, just write down how many times you think a heart surgeon might see the mitral valve a year. I will tell you that on this research that you can see in front of you, we felt that there was about an inflection point of about 25 mitral valve operations a year when the repair rates got consistently good and people got really safe. So if you did more than 25, you were good. And right now, I think if you want to be an American Heart Association kind of approved mitral surgeon, the number's closer to 50. So bearing those two numbers in mind, 25 to get consistently good, 50 to maybe get recognized by the American Heart Association. How many times do you think the average cardiac surgeon in the US sees the mitral valve a year? It's less than 10 times, single digits. And wow. That's just astonishing, because you saw the variety of those valves. How can you get good at something that's so variable and complicated if you're only doing it, you know, maybe less than once a month? And that's why you really want to go to centers where they do a lot. Look at this graph again, though. Here, out at 150 mitral valve repairs a year is a surgeon who only has a 70% repair rate. So it's not just about the volume. It's honestly about the expertise. And most of us in one of the slides that I'm going to show you have published our own programs data and our own individual data. And we all aspire to and are close to 99% repair rates. And these are centers that have all done, you know, really over 1,000 repairs. That's really what you're looking for. If you've got a Barlow's valve, certainly if you're young and you really want to repair, that those should be real drivers of the surgeon that you pick. And it's not just about the convenience and the closeness. It's hard to travel for things like surgery, but this is probably one type of surgery that it's worth traveling for if you need to.
Absolutely.
And this is the American Heart Association's effort to help make this process easier, where you could identify centers that meet some of those volume thresholds. And I think this is really, really helpful and really important. These are centers that do mitral valve repair more often than a sort of minimum standard. I think it's about 50 a year, and they do it well. They have 90% repair rate, so that's pretty good. Patients often come to Cedars and to me specifically because they want more than just that minimum standard. They also want, frankly, they want a robotic repair. And if you show us the next slide, I'll usually tell them these are the centers that I would think about in the US that are experienced robotic mitral repair centers with great surgeons that will really maximize your chances of getting a great repair. And you can see that you've got a good amount of choice on the East Coast, a fair bit of choice in the middle. I should probably put Mayo Clinic on there as well. And it's a little bit more limited on the West Coast, but it's select. There are not many centers that do mitral repair well, and there are certainly not many centers, far fewer, it's a handful of us, that do robotic mitral repair well. So let's go on to the next question. Oh, there's a great question from John Stott in this context, which is, don't all doctors feel that their opinion is always best, and won't they be offended if questioned? All I can say is, if you're asking a mitral surgeon, I think just go if they're offended if you're asking this level of question. We have advised people to ask this because it's so important. And if somebody doesn't know the answer or can't give you a good answer, you definitely got to think very hard about staying with them for surgery. If the answer isn't right, if the answer is, I don't know, I'll take a look at it in the operating room and then decide it could be a repair or replacement. Those are really not the right thing to hear. You want to hear somebody that has done hundreds, has a 90%, ideally more repair rate, great safety outcomes, and can look at your echo and say, for your echo, I am confident that this will be a repair. That's just really important.
Yeah, and if I can jump in real quick, because I know obviously Wendy is enamored with her surgeon, right, Dr. Chikwe? I know I've been blessed to have Dr. Starnes help me out along the way. But at the same time, it can be very anxious and nerve-wracking, to say the least, when you are having that consult and you're asking questions when you may have just recently been diagnosed, or you haven't fully had time to process everything that is happening to you. I'm curious to know, Wendy, you seem like you were one of the top advocates out there for yourself. Did you write down all your questions before you talked to the physicians? Did you record your sessions so you could? Yeah.
I wrote them down. Sorry. I absolutely wrote them down. And I have to say, I had 2 or 3 cardiologists that were not in agreement that I needed surgery. I had one cardiologist I went for a second opinion when I was diagnosed and told I needed surgery, that would not even look at my echocardiogram. He listened to my heart, called himself the heart whisperer, and proceeded to make noises like a heart and said, your heart's in fine shape, you'll outlive your surgeons. And that was it. So yes, you can. I was absolutely an advocate. I was assertive in my quest. I had a daughter that was helping me out with it. And we just, I would say probably a month, just read everything we could read about it. And like I said, I was scheduled for a particular place, and found several doctors and sent my echocardiograms to a couple, and I just kept asking questions. My conversation with Dr. Chikwe was a half an hour, really getting a reference for somebody else, and she was gracious enough to accommodate with me with that. And by the end of the conversation, she was the person for me. Absolutely, no question, didn't matter where I had to go. So she answered all my questions and then some. And her follow-up end of conversation was, have I answered everything I can answer for you? Which is so reassuring.
Yeah.
So if I had to call her again, I felt like I could do that. So I think that's what you need to look
That's been
for.
the beauty of Zoom and remote. So you can have a very low stakes conversation remotely now with a lot of surgeons, and you could have more than one. You can go away, process it, digest it, run it by your cardiologist, run things by families and friends, and then come back. And I think that's really phenomenal. It means you don't have to get in a car or get on the plane and then be committed. And secondly, it opens up the avenue for you to get a second opinion. And if it's right for you, a third opinion. There are good people out there that will happily see you and have an intelligent conversation about you and your valve and what are the right options. And it's just really important. It's a big thing to get right.
I met Dr. Chikwe the day before my surgery in person. I felt like I had known her. And for me, what I had said is, I know this is a life-changing diagnosis for a lot of people. However, from the surgeon and the staff's point of view, it's a routine that they do every day if you find that skilled surgeon. So there was that point where you had to let your anxiety go once you've chosen what's correct for you, and take that leap of faith, and then know you're putting your hands in a very skilled staff. And that became my mantra. It's not for them, they know what they're doing. For me, this is a one-time in a lifetime prognosis, and you have to turn it over at that point once you're comfortable. And so I never looked back. I never doubted it. I was actually quite calm with my anxious family the couple of days before. Like, I just had to go into it knowing that I chose well.
Adam, there's quite a few questions, and yeah, this one's a great one. Jeff asks, I was recently diagnosed with mild mitral regurgitation and told that I could require surgery, but not for decades. Is there anything I can do now to stop the leaking from getting worse? That's a tricky one. And generally, it's the common sense things like good blood pressure control is probably key. That can stress your heart. You don't want to get any other heart problems. So the regular things like cholesterol, blood sugar, great exercise. There aren't any really medications that you can take to avoid mitral regurgitation progressing. And the chances are, if it's mild, is that it will probably stay mild. I'm surprised somebody told you that you could require surgery in 10 or 20 years if you've only got mild regurgitation now. A huge part of the population is walking around with mild mitral regurgitation, and they're never going to need surgery. So please don't worry too much about that one. There is one question from Carla. I have moderate mitral regurg. So now we've gone from mild to moderate. Moderate is not needing surgery, but it sounds like Carla may have already had surgery and now she's got a leak. And her question is, what happens if a surgical repair fails? Are re-repairs performed surgically or using catheters, and what are the outcomes? And that's a really great question that a couple of people in the chat have asked as well. So a lot of this depends on what was the cause of your mitral regurgitation in the very first place. If you had a floppy valve and you've had it repaired, it's often possible to re-repair it if that fails. It sort of depends on why it failed. If a repair fails within the first few months after surgery, that's usually because of something technically problematic. It's not usually because disease progressed, and it's not usually because you got an infection. And if there's a technical challenge, that can be straightforward to sort out. If it fails very late after surgery, like 5, 6, 7, 8 years after surgery, that's oftentimes because the disease progressed, and that often is amenable to re-repair. The key thing is it's a judgment call. We talked about before, you want a surgeon that can say with confidence, based on your echo, I'm going to repair that. This is for first-time surgery. Second-time surgery, it's much more of a judgment call in the operating room, because you're really trying to balance the chances that this re-repair will last well versus it will just be safer to replace the valve. To maximize your chances of a surgeon making the right decision, you want to pick one of the 3 or 4 centers that has really good experience in re-repair, and there are not many of us. But I would say Cedars, I would say Mount Sinai in New York, I would say the Cleveland Clinic. Those 3 centers have probably got amongst the biggest experience in re-repairing failed repairs, and we get them from, frankly, all over the country.
And Dr. Chikwe, maybe we can shine some light on that, because if I'm a patient, I'm hearing, oh, I need a re-repair. Okay, they're just going to go back in and redo what they did earlier. Are there certain risks or complications that occur for a re-entry into the heart, or no?
That's a terrific question. And what I would say is there are the risks of just trying to get back in safely. After you've had first-time heart surgery, your body responds by making scar tissue everywhere that was frankly exposed to air. So it's trickier to get back in second time. And that's why centers that have expertise in doing second time surgery can do it safely. They're very practiced at dealing with all eventualities. And that's really important. Then there's the challenge of addressing a valve that is now completely abnormal. And that really does require a higher level of skill and experience to do that successfully. Transcatheter repair, where you could have the valve reconstructed via a blood vessel in your leg, is increasingly an option for people that may be too high risk for surgery. But it's generally rarely possible to re-repair a valve using a transcatheter approach. There are lots of reasons for that, but essentially it's challenging. And then there's a very small number of patients where you can replace the valve by a blood vessel in the groin after failure of a previous repair. The outcomes of that have not been great. And again, there are a number of reasons why. So the bottom line is if you can find the surgeon that gives you a durable repair so it doesn't fail, that's front and central number one. If it does fail, pick a center that's expert and has done a lot of second time surgery, because that will really maximize your chances of having a good long-term result. And a few people have mentioned calcification after valve surgery. It's really common. All calcium is the body's response to an abnormal valve. So your own valve can calcify, and that's why people get stenosis, mitral stenosis or aortic stenosis. But after you've repaired a valve, occasionally, because it just isn't normal anymore, it can calcify. And that's quite challenging to deal with. We don't have great options. And if you've got a calcified valve, most surgeons will be very, very cautious about offering you surgery. We want to do everything we can to maximize your quality and length of life without going in there and digging out the calcium again.
Yeah, and Dr. Chikwe, as they say, time flies when you're having fun, and not that heart surgery is fun by any means, but you and Wendy have made this session very fun. We're coming close to the end of it. We've got a survey that we're going to do. Do we have time for maybe another 3 or 4 minutes of discussion, and then we can wrap up with the survey? Does that work with you?
Thank you for the heads up. So I think the last few slides I want to focus on are really about echo. So let's go past mitral valve failure rates, because we talked about that. Here's a question from Marie, and it mirrors some of the questions in the chat. When the doctor shows me an echocardiogram, I have no idea what I'm looking at. What should I know when I'm looking at an echo? So the pictures are hard to look at. And what I'm going to do is show you some reports. You can all ask for the report from your cardiologist. So if we go to the next slide, there are really just a couple of things to focus on. So here's a report, lots of numbers and lots of text. Where do I even start? Let's go to the next slide. So before surgery, you're looking for something that says severe regurgitation or severe stenosis. And that's really the reason for having the surgery. That's really all you need to see. If none of the valves have the word severe next door to them, question what the rationale is for valve surgery, that there needs to be severe in a sentence next door to your valve. Then the next slide is the next thing you look at before surgery is this, and this is about your left ventricle. The left ventricle is the powerhouse of the heart. Ideally, we want to keep it normal. When it starts to fail, so people start talking about it's dilated or it's not ejecting well, that's sometimes a trigger for surgery. And then after surgery, we've got one last slide here. The key thing then is to go back and look at your valves. So here's an echo from after surgery. Again, lots of numbers, lots of text. All you want to see is that it says no or trace regurgitation if you've had a repair, and that things have improved. So look for severe before surgery next door to a valve. Look at anything that talks about your left ventricle and see if that's normal. And after surgery, what you want to see is no or trace regurgitation or stenosis. Now I'll stop there because people take years to learn how to read echoes, and me doing this in 3 slides in 3 minutes is not going to do it justice.
Okay, and do you have time for maybe one more? Actually, we talked about mitral stenosis earlier. Maybe we can wrap up with this one because you are seeing things in clinical trials. You're talking to medical companies that are working on new innovations. When you look out 10 years, Dr. Chikwe, how do you see mitral valve therapy transforming?
So it sort of ties in with mitral stenosis, which for a long time we've been able to treat via a blood vessel in the groin. So you don't have to have your chest opened or open heart surgery. And we've only just started extending that to mitral valve regurgitation. So if you move to the next slide, this is something that I think is exciting. So this is the MitraClip, which many of you have already heard of, which is, again, a way of repairing a floppy mitral valve through a blood vessel in the groin with a clip that essentially clips those 2 leaky leaflets together. If we go to the next slide, we don't know if that's the right thing for a patient with a floppy mitral valve. It's certainly the right thing for somebody who's too sick for surgery. But for somebody who's younger, it's not clear that that's the right thing. And for those of you that are interested in participating in a clinical trial, Primary is a trial that is sponsored by the National Institutes of Health. So that's the absolute gold standard for clinical research in the US. And essentially, we're recruiting all patients aged over the age of 65 that have mitral regurgitation due to prolapse to find out if a clip or a surgical repair is the best option for them. It's really genuinely exciting, and it's probably the only option for people that want a clip that are not super high risk for surgery to get a clip.
Well, on that note, we're going to wrap this up, but please don't jump off the webinar just yet. I want to extend a tremendous thank you to Dr. Chikwe for sharing all of her clinical expertise and research with us. And Wendy, I can't thank you enough for being a really just an amazing advocate for yourself through your entire surgical journey from diagnosis to recovery. It has been great having you on the webinar. I also would like to thank all the people on the line today. Just by being here, you're making a difference, not just in our community, but in your own health. And that is what our goal is all about, keeping and making you healthy and getting you and your valves in the best shape that they can be. And as we wrap up today, I'm just going to again say thank you to Dr. Chikwe, thank you to Wendy, thank you to you. And now, if you could please complete the survey, that would be a great end to this session. And again, Dr. Chikwe and Wendy, thanks so much for your help today.
Thank you.
Thank you both very, very much. And thank you, Wendy, in particular. Thank you.
Hi, everybody, it's Adam. I hope you enjoyed that video. And don't forget, you can always subscribe to our YouTube channel, watch the next 2 educational videos coming up on your screen, or click the blue button to visit HeartValveSurgery.com.